Great question. As you mentioned, AI is everywhere, including healthcare right now. And I think there's a lot of acceptance and also hesitations with usage of AI. And I would say in general, in the field of OB, we're always a few steps behind everybody else. And if we think about like prenatal ultrasound, um, it's radiology, right? And outside of obstetrics, AI assistant is used very prevalently and very accepted by the radiology colleagues. But it really hasn't been um, prevalent in prenatal ultrasound. And so last year we did a reader study which looked at AI assistance, whether it helps OBGYNs and MFMs in terms of improving their detections for fetuses at risk for congenital heart defects, which is one of the more common birth defects, and obviously has pretty significant impact if you miss that diagnosis, but it's also very commonly missed. And it showed a market improvement with AI assistance. However, that was a very study-based environment where 50% of the cases had an abnormality. And so a lot of people's question is really, well, how does that apply in the real world when the incidence is about 1%? Like, does it perform as well? And so that's where the motivation for this study came in, where we wanted to just implement it in our practice because it's an FDA cleared device, and really see how does it perform in our center, which is in general, I would describe it as a um, uh, very scan heavy, very, we're very specialized. And so typically don't miss any heart defects, but just wanted to see how does it compare to what we would normally um, suggest or see. There are a few AI assistant software out there in terms of prenatal ultrasound. We use the program via a company called Brightheart for a few reasons. One, it really doesn't require the sonographers to change their normal routine because it's not something that is machine based. It's not ultrasound machine based. You can use it for any ultrasound. It's a cloud based software program. And so the way that we implemented it, was that we added a cart side tablet right next to the machine so that when the sonographer is scanning, typically they'll send images to our usual reading platform via DICOM, but it will also separately send DICOM images to Brightheart's cloud-based system after anonymization. And so it's pretty real time as possible. And so the AI software is analyzing the images that is being obtained and the clips that's being obtained as the sonographer is still scanning the patient. And then they can see, they get these sensors on the tablet that tells them that they get the images that's required for the AI to analyze. So specifically, we need clips of four-chamber heart, left ventricular outflow tract, LVOT or RVOT. And then once they could get that 2-second clip, then the AI software can analyze it. And the analysis is usually like completed before the sonographers are even done with their entire anatomy scan. So they kind of get an idea, like, is a green light go, everything's fine, or is there something maybe you want to take a better look at because there might be something there. And then the way from what we do is that after the anatomy scan, the sonographers will come to uh, the the MFM, the physician that's there, that's reading it, already knowing what the AI software has said, but we also get to kind of look through the platform on our web page. But we'll read the scan like we normally do. We'll decide whether we think there's something suspicious or not, and counsel the patient accordingly if there is a finding. I think there's a fear of replacement, right? And I think the this particular program and in general, I would never I would always kind of use the word AI assistance because it really is just assisting us, right? It's maybe in our center because we're so specialized in general in fetal prenatal diagnosis, but also in the fetal heart, that yeah, for we don't necessarily need a software to tell us is there a heart defect or not. but it might help improve efficiency, right? Like, so um, if you've already attained all the images, there was already analysis, you're probably, it makes things faster, I would say. Even though we can't, it's very hard to test time differences, particularly in such a busy practice. But I would say our experience has been it hasn't really added time, which is very important to us because of how busy we are, and in some ways it's sped up things. Just in general for the that we looked at how the software performed in a 7 month time period prior to submission of this abstract. Um, and in that time period, we had four severe congenital heart defects, and thankfully the AI did pick up at least one finding in those four. So it, I guess you could say sensitivity is 100%, but I think we're hesitant to say that because it's still just a 7 month time period and only four cases, right? Um, but that was good. And then there were two additional cases that were not necessarily a heart anomaly, like it's not a birth defect of the heart, but there was something else going on with the baby that affected the heart, whether it's a cardiomyopathy or positioning of the heart. And they were also the AI software was able to pick up those two cases too. So those are like your six kind of representative severe cases for the baby, right? Um, but what was also important, not only to know that they picked up all these severe cases, was also, okay, well, how often does it flag, right? Like how often do I have to do a second look? How often do I have to be worried or look? And that's also important because that will add into efficiency, right? Like if you're like, okay, it's flagging all the time, then it's not that helpful. And so that's where the specificity came in, where the overall flag rate in that 7 month interval was a little over 3%, which is, if you think about from a screening test standpoint, the false positive of about 3% is really not bad if they picked up all the severe cases. What's also very reassuring was we looked at kind of like the from implementation to the end of that 7 months to see how frequent the sonographers were able to obtain those clips because that's a little bit of a change of their usual like standard, right? Like they'll do a clip, but maybe it's not quite 2 seconds, right? So if you look at the 7 month time period, it was only a 77% completion rate, which isn't great. But then if you kind of space that out by months, by the fourth month, it was over 90% completion rate and it stayed above 90% after that. So it was just a learning time period for learning curve for the sonographers to do that. And then if you just take a snapshot of the time period where the completion rates for these scans were above 90%, the false alarm rate was only 1.5%, which is phenomenal. So that really doesn't add too much to our load at the unit, right? I think more than 1% of the time in general, we're probably second guessing ourselves on the heart. So this is pretty good.